Hello everybody, thank you for choosing to watch my virtual presentation. My name is Dr. Tim Swinn. I'm a clinical fellow at the Bristol Royal Infirmary, and co-authors on this project, Dr. Charlotte Hayden and Dr. Nick Bell, are colleagues of mine. This presentation will talk through a quality improvement project that improved the written weekend handover system in our hospital quickly and sustainably during a time of high pressure from the COVID-19 pandemic. We'll talk through the underlying issues, the cycles of the project, the improvement that led to, and finally reflect on learning points that can be taken forward into future quality improvement projects. During the January peak of the COVID-19 pandemic in the UK, our hospital had a high number of medical inpatients, many of whom had to outlie on surgical wards. This created atypical patient flow through the hospital and highlighted inflexibility in our written weekend handover system, primarily its inability to track location. This resulted in junior doctors having to spend over an hour each morning on a Saturday and Sunday checking the accuracy of their lists, and this time could have been dedicated to patient care. We knew that we had to solve this problem and that we had to solve it quickly because it wasn't going to go away. As a result, we came up with the following SMART goals on the left of your screen. We wanted to improve accuracy of location to 100% within a week, and the more sustainable goal, number 2, was to improve handover quality over 3 months. After consulting the Royal College of Physicians Acute Care Toolkit, we came up with the 8 elements that we think make a perfect handover, displayed on the right of your screen. The graph you see in front of you shows prevalence of groups of key handover elements through several cycles of our project. The baseline data, in orange, shows that demographic and location information was only accurate 2/3 of the time, and this was the stat that we really wanted to get right. Cycle 1 was implementation of our new system, named CareFlow Workspace, and you can see that this improved demographics and location to 100% within a week of implementation. This was by dynamically tracking location through tying in with existing management systems. Subsequent cycles followed feedback from the previous cycles and wanted to improve other key handover element prevalence. Cycle 2 was an amendment to the standard operating procedure, aiming to increase the background information and the task accuracy. And Cycle 3 was more widespread user education, aiming to boost the grade of doctor reviewing and the day you wanted your job done. And the key element here is that after all these cycles, the proportion of handovers that include all elements has increased by an absolute percentage of 21%, and this has been sustained across 3 months. Future cycles include IT upgrades to boost the grade and day statistics even more. Secondary analyses of the efficiency of the system included timing junior doctors to upload a 4-patient list to the weekend handover on the existing and the new system. The existing system, named Go-To Handover, has boxes in orange, whereas the new system, CareFlow Workspace, has boxes in grey. And you can see from the box and whiskers plots on the right that the total time is significantly reduced. This was a saving of 154 seconds for a 4-patient list, 39 seconds per patient, and this would equate to a saving of 69 minutes of junior doctor time per week based on a standard length handover list. Additionally, we surveyed junior doctors 2 months after implementation to assess user perception on the new system compared to the old. We used a 5-point Likert scale, with 5 being the best in each domain, and we were particularly pleased to see that user perception of system safety had improved with the new system from 3.2 to 3.9 out of 5. Comments suggest that this is primarily due to the accuracy of location and demographic data. Our project provides an example of how sustainable change can be implemented rapidly during a time of adversity, and we think there are learning points to be taken forwards. We used what we have termed accelerated PDSA methodology to help us implement this project, and this involves speeding up the plan and the do steps through efficient learning methods. We used enhanced collaboration with local centres with experience using CareFlow Workspace and informal focus groups. Enhanced collaboration was a feature of many aspects of the pandemic response, and in this instance it helped us learn from their experience and foresee potential teething issues and act prospectively to avert them. This alone, however, would not be enough for a successful project. Accelerated implementation carries with it a higher chance of error and unforeseen circumstances, so is reliant on robust re-auditing as we have done. This allows you to continually improve your system as you gain more information as to how it's working in your centre. We also found that harnessing the momentum of the pandemic and focusing minds allowed us to implement quickly. Thank you very much for listening to my presentation. If you have any thoughts, suggestions or feedback, I'd love to hear from you. My email address is on the screen and the references are below. Thank you.